Well, good day, everyone, and welcome to eCancer. So happy to have an opportunity to moderate a program with such an esteemed faculty, great colleagues and friends. I'm Neal Shore. I'm a uro-oncologist in South Carolina. We have today another uro-oncologist, Prof Saad, a professor of urology in Montreal, and two professors of medical oncology, Andy Armstrong at Duke University and Eleni at MD Anderson. Now, how fitting to have urologists, medical oncologists in different parts of the world reviewing the importance of new developments from ESMO 2021. We're going to focus today on PARP inhibitors. As we all know, PARP inhibitors have come into their own starting in 2020. Wonderful data from the PROfound phase 3 trial has led to level 1 evidence for the use of PARPs, as well as the Triton 2 trial in MCRPC patients who've progressed after novel hormonal agents. There's different gene alteration profiles which allow for their use. And there's some different regulatory approvals, but nonetheless, it adds to the now 11 life-prolonging therapies in MCRPC. There are some important issues about when to test, why to test, how to test. I hope our panelists, touch on that as well as their personal experiences. But what really came out of ESMO 2021 was some really interesting and provocative data on combination therapy with the use of immunotherapy, combinations with other agents, and also testing and utilizing therapy for patients who aren't necessarily having homologous recombinant repair alterations, and even some very provocative data on the use of bipolar androgen therapy, also known as BAT. So let me get started then, and let me ask you, Fred, first. You're using PARP inhibitors. Your use of PARP inhibitors in the clinic, but also now how you're thinking about them in terms of combination and sequencing, and any of these particular abstracts from ESMO 2021 that jump out for you.
Yeah, I think we're all really looking forward to the day when we stop using only monotherapy in prostate cancer and start to combine, because it just makes rational sense. We're not treating a homogeneous disease. There are different facets, and one of them is homologous repair mutations. So it just makes sense to combine things with a PARP inhibitor. The low-hanging fruit are novel hormonal therapies like abiraterone and possibly enzalutamide. Given the preclinical data that suggested maybe combination with a hormonally based therapy encourages an environment that makes the cancer more receptive to PARP inhibition. And this was actually shown, or at least implied, in a phase 2 study that showed that in a non-selected population, we were able to delay radiographic progression-free survival in study 8 that was published a couple of years ago. And now I think everybody's very excited because there's a press release that came out saying that PROPEL, which is combining abiraterone to olaparib, met its primary endpoint of delaying progression-free survival in an unselected population. So obviously we're all looking forward to the details of that, but that may change how we view patients that are in first-line MCRPC.
Yeah, great point. Eleni, let me ask you, what do you think about the use of the different PARP inhibitors that are in MCRPC that are looking at the complete all-comers pool, so to speak? We see in the TALAPRO-1 abstract using PARPs, their potential in non-DDR mutational landscape.
Thank you for that. And thank you, Fred, for your comment. I'm a little baffled by the press release. I'll be honest. It's not what I expected. So I'm being cautious in my comments till we see the magnitude of the impact. And it's obvious that it may be very well like what we saw with ACES trial, even though it's not enough mature data. Remember, we saw just recently a very big trial that took forever to report, and we know it because we were part of the trial with Fred, we were living through it. It showed a wonderful primary endpoint success with an rPFS that is quite large, but no OS benefit. And again, even though that was the secondary endpoint and the combination was different to androgen signaling inhibitors, the way the community has received it, and it's too early, is as if it may not be practice changing. So we need to be very careful. Granted, these are two different mechanisms of action. When Clark et al. Had reported that previous phase 2 study of the combination, again, a lot of us were really surprised to see such an impact in the population that is non-DRD. And if you look carefully at the phase 2, at least ESMO data that reported, again, there doesn't seem to be a clear signal for the non-DRD population if you just go straight with PARP inhibition plus an androgen signaling inhibitor. So I would just hold my impressions until we look at the granularity of the data that unfortunately was not presented at this ESMO. I guess it was a cutoff of time.
Yeah, it's a really fair point. And of course, whenever we combine, as you know, you championed the ACES trial, and now we're looking at combining PARPs, different PARPs, albeit with abiraterone, albeit with pembrolizumab or with enzalutamide. It's really interesting, just from a practical standpoint, what is the potential for any added toxicity? What is the potential of economic issues and accessibility? But Andy, can you comment on how the mechanism of action can be enhanced for a PARP inhibitor when you add another therapy? We talk about this concept of increasing PARPness. Would you comment on that, please?
Yeah, thanks for that, Neal. I think ideally a PARP combination will show synergy molecularly and clinically, where the PARP inhibitor may leverage the biology of the other inhibitor to generate more clinical benefit than you would get sequentially with these drugs. With an AR pathway inhibitor, we know that AR regulates DNA repair. DNA PK and homologous repair enzymes are actually regulated by hormonal signaling, and that's the basis for our radio sensitivity in early disease, where we know that cure rates are greater with IMRT and ADT. And we're seeing from the ESMO presidential session that the STAMPEDE data with 2 years of abiraterone phenomenally improves survival in early localized disease patients, where we're now going for cure. And so the idea behind using abiraterone, ADT, which can induce a synthetic lethal relationship with homologous repair, and then combining that with a PARP inhibitor, basically you're creating a BRCA-ness state for patients without homologous repair. You're creating a homologous repair deficiency that you can then leverage to use the PARP inhibitor and broaden the potential scope for that PARP inhibitor to benefit patients beyond the 25% of patients that we know have germline or somatic alterations. That's the hope. But like Eleni said, we need to see the progression-free survival magnitude. ACES was a great example. Same with the Alliance Abi-Enza combo study, where progression-free survival delays of only 5 to 6 months did not translate into an overall survival benefit. And that's likely because of cross-resistance and the emerging data that maybe post-progression survival could be shorter. When you're breeding a tumor that's more aggressive later, those may be harder to treat. And so, the added toxicity, the added costs really have to be worth it. So we want to see data on the magnitude of the benefit and the toxicities, the risks, and the survival data. The other combination that's possible is the immunotherapy combination. So at ESMO, we saw many abstracts looking at pembro plus olaparib, and that's a subject of an ongoing phase 3, the KeyLink study. It's always challenging to interpret single-arm studies without control groups. I would just make a major commentary there that it's very hard to make speculations without comparing it. But here the idea is that the PARP inhibitor may induce PD-L1, a stress response that may lead to more recognition by the immune system, and you can leverage that towards an anti-PD-1 therapy. But the actual data has been a little bit under impressive, I would say, from from ESMO and the data that's been presented so far. We don't see an overwhelming synergy of objective or PSA responses that's translating into very durable progression-free survivals, only 5 to 6 months in the abstracts presented here. So I'm a little bit skeptical of that approach. Certainly, it may be better than using a second AR therapy, which we know doesn't work and we shouldn't be encouraging. But maybe not as good as PSMA lutetium or the CARD trials and cabazitaxel, which would be probably a more effective standard for these patients.
That's a wonderful summary. Yeah, we're constantly thinking about why is the description of prostate cancer as being a cold immunologic microenvironment, as we often say. How do we, get it in a more robust microenvironment for immunological approaches? And I would agree with you. Do you think there are going to be any subset or potential biomarkers that can enhance the use of a checkpoint inhibitor with combination with either an AR inhibitor or a PARP inhibitor, Andy?
That's a great question. We have biomarker defined subsets already that, you can use Pembro, for example, on label in prostate cancer for the MSI high patients, those with TMBs above 10. Those are mostly overlapping groups, but not always. We have some retrospective multi-center studies showing CDK12 is a unique population that might have a enrichment for PD-1 responsiveness, but not prospectively validated yet. We published last year a small subgroup characterized by loss of a gene called LRP1B, and that was published in the Journal of the Immunotherapy Consortium, JITC. And we're trying to validate that now in prospective studies of these PD-1 inhibitors in prostate cancer. But I would say we still don't know. I mean, the idea behind using a DNA damaging agent is to induce more tumor neoantigens so that the immune system can then be engaged, infiltrate the tumor. And we just haven't seen that combination yet work. It could be that platinums plus a PD-1 could do it, or a PARP plus a PD-1. It might take several agents, several checkpoints.
Yeah. Fred, let me ask you, you've done a lot of great work in PROMs, patient-reported outcome measures, and health-related quality of life assessments. As someone who's doing the research and practicing and prescribing, as are clearly Andy and Eleni, what are your thoughts regarding, these combination therapies, our patients with MCRPC, adding, a PARP inhibitor to other therapeutics in terms of just maintaining quality of life, keeping patients out of the emergency departments and out of hospital?
Yeah, no, clearly, I mean, we're all very involved, really enthusiastic about prolonging survival, but it shouldn't be at all cost. I mean, these patients are not 20-year-old patients. These patients are very concerned about quality of life. And what is reassuring is that even though PARP inhibitors do have a certain amount of adverse event possibilities, every time we look at quality of life, these patients do poorly if left alone or left with whatever we can offer them. So it is quite reassuring that with PARP inhibitors, every time we've looked, we've actually either maintained quality of life or actually improved quality of life on several points, including pain, including overall health-related quality of life. TALAPRO-1 was presented, again, the limitations of a single-arm study, but I think we can, get information in terms of quality of life with a single-arm study, because you use the patient's baseline as the control. They come in with a certain amount of quality of life, pain, and then you look at how you're able to improve it. And we were actually able to significantly improve many outcomes, including pain and pain progression in patients in TALAPRO-1. Same was seen with PROfound. A lot of very intriguing and very encouraging quality of life outcomes in PROfound. And so obviously now, when we start combining, again, the quality of life is going to be looked at. We're in the process of publishing the study 8, the combination of olaparib plus abiraterone. And again, quality of life is either maintained or actually improved in a significant proportion of men. So I think it's quite encouraging, and we shouldn't be discouraged to using PARP inhibitors with the worry of worsening quality of life, because that hasn't been seen, at least in the studies so far.
So let me ask Fred another follow-up to that. So when you're talking to a patient and you're considering initiating a PARP inhibitor on label with regulatory approval, what's the conversation that you have with them just in terms of their expectation of any particular side effects, and how are you going to monitor them?
Yeah. So, what we tell patients is that the first few months are the most revealing. And so these patients need to be monitored on a regular basis, usually every month, because there is a risk of anemia development. There is a risk of some thrombocytopenia. There is a risk of some fatigue. But much of this is quite easy to manage in patients that are followed adequately. And when we look at overall adverse events, they're not very dissimilar to the non-treated patients, especially when you consider that most of these patients in PROfound or other studies are exposed to a much longer amount of time to a PARP inhibitor than in the control arm, where they drop out of the study much quicker. So overall, I think very manageable. Obviously, it takes a little bit of experience. I wouldn't encourage, both of us are uro-oncologists. I think we're very comfortable, but this is not for the average urologist that dabbles. I think you really have to work with your medical oncologist to be able to ensure that patients remain on study. The worst thing that could happen is that a patient stops drug too early because of difficulties in managing some of these adverse events.
Yeah, thank you. Eleni, what's your testing algorithm? Patient comes in, referred into MD Anderson, and they haven't undergone any genomic profiling. They show up with MCRPC, and they have perhaps progressed through a novel hormonal agent, whether it's abiraterone or enzalutamide. What are your teachings regarding genomic profiling?
Thank you for that. It was like you were reading my mind. I was listening to Andy and Fred, and I was actually thinking, here we are talking from a perspective of people who have the luxury to not be in everyday practice and be running around with like all sorts of solid tumor treatment in a small practice community. We have that opportunity and the knowledge and the experience to request germline testing when the patient walks in the door. I actually do it from baseline, even at the hormone naive, from high risk and kind of more progressive stage. And then somatic assessment, which may be repeated over time. However, my concern here is not what we do in our clinics, is what is actually happening in the community. And you mentioned that the patient would be coming in without an assessment. And that is unfortunately the reality for the bulk of the patients who are referred to us, and I believe pretty sure to you too, because of many reasons. A very big part is educational, obviously, and another part is downright everyday pressure and practice and not availability of time to do it. So it is very important that we take the time to check off the box and put it as a system-wide approach in our clinic, the similar fashion that we have the PSA, the testosterone, even the baseline biopsy, I would say. It should be an integral part of our practice now. The danger that comes about with the potential of applying an agent across all patients is that we may be moving backwards a little bit, and that is not correct because, as Andy pointed out, we really need these biomarkers to even understand resistance. There was a beautiful paper reported a couple of years ago, I believe, the PRO-REPAIR trial that made the first effort to try to understand other molecular parameters that may be playing a role in the resistance that we see to PARP inhibition in the presence of DRD event. So these efforts need to be continued so that the panels can be expanded, and eventually we don't look at events in a univariate fashion. It's never a univariate event. I am very, very concerned when we give out results that are across the board, because in that fashion, there's a danger, like we had this discussion recently with Vision trial, that we may not need to make that first step to assess the molecular parameter, or in that case, the imaging molecular parameter that is needed. And I'd like to hear your thoughts as well, because I think that's a very important part of the discussion.
I appreciate that, but let me just, in a very simplistic way of asking this. So this same patient, MCRPC, progressing on an NHA, ABI, or ENZA, has not received any profiling. I'm curious if anyone on the panel would not do anything other than immediately order both germline and somatic testing, tissue if it was available, and liquid if tissue was not available. Would anybody not immediately order both? So it looks like everybody would do that, would concomitantly on initial presentation. Andy, can you comment on the concept that, well, okay, I'm going to order the archival prostate tissue for somatic assessment, but now the patient has metastases, big lymph nodes. What's the thought process of truncal mutations versus evolving mutations? How common is that? And do you do sequential somatic testing?
Great question, Neal. We know that the trunk of the evolutionary tree of prostate cancer often involves genes like BRCA2. And that's probably our best target for olaparib, where the most profound results have been seen, literally from the PROfound trial. And so most BRCA2 mutations are truncal, although I have seen, I'm sure all of you have seen patients with acquired BRCA2 somatic alterations only. And so that you can have a two-hit finding with somatic only mutations. Most of the cases can be discovered through prostatectomy or initial hormone sensitive biopsies. Many of those are archival, and we know that tissue degrades, that there's inadequate tissue. So that's a frequent problem. Like in the PROfound study, 40% of the patients failed tumor testing because of those archival issues. FNAs are often inadequate, cytologies, and even prostatectomy samples can have degradation artifacts. So getting a fresh metastatic biopsy would be ideal, but it is invasive. The issues with cell-free DNA testing are confounded by tumor burden. So you have to do it right at the time when the patient's really having progression, not when they're responding. Otherwise, it'll be an uninformative test. There are issues of clonal hematopoiesis, where there's the same DNA repair mutations, but not in the tumor, they're in the blood. And you don't want to treat the patient if they have CHIP. You know, that's a risk factor for cardiovascular disease and death. It increases with age and smoking, and can be an indicator as a pre-malignant condition of hematologic malignancies, but we don't want to necessarily be misled to thinking that's in the tumor. So having some orthogonal validation approach using the tumor or the leukocytes to confirm what you're finding is actually real is very important. So I'll leave it there.
No, those are important points. You know, better understanding the implications of CHIP, I think we continue to evolve on. And just the notion around molecular signatures for various companies that are, you know, looking at this now in response to therapy. That's an evolving field that we all need to be paying attention to in the trials that are coming forward there. Fred, you know, we're seeing at ESMO 2021 reports on the use of other PARP inhibitors that are improved in other tumor streams. And certainly for our prostate-focused colleagues, medical oncology, radiation oncology, urology, the PARP inhibitors have had a long history in breast and ovarian cancer, most recently also in pancreatic cancer. I'm curious, Fred, and maybe Eleni or Andy, if you want to comment. You know, we have two PARP inhibitors that have met regulatory approval in EMA and FDA for olaparib and rucaparib, but now we're seeing additional studies with niraparib and talazoparib. Fred, do you think that there will be any sort of defining or differentiation amongst this embarrassment of riches for PARP inhibitors?
I think that the trials are going to hopefully answer those questions. It's very hard. I mean, I've worked with several of them. I have to admit, they've all shown impressive degrees of efficacy. Now, there are subtleties in adverse events, and I think none of us would like to, you know, because we had a bad experience with one, to claim that this is unique to that drug. So I think I like to look at more data, but I think it's reassuring that all of them are showing efficacy. All of them are well tolerated. But it would be interesting. I mean, we're talking about biomarkers for efficacy. It would be very interesting to develop biomarkers for adverse events or toxicity. I mean, I think we'd all like to be able to say, with this profile, that there might be a selection of one over the other. The same example as for AR targeted therapies, where somebody who has a risk of seizure, we would tend to use darolutamide than any of the others. And so it will be interesting in PARPs. I don't have enough experience. I think Eleni and Andrew probably have much more experience since they might have used these in other tumor settings or for longer periods of time.
Yeah, Eleni, what do you think? Is this will there be a differentiation, or will it be sort of, unless somebody does a head-to-head prospective study, it'll be sort of you're based upon real-world experience?
You insinuated relatively to it that there is a concern that if we have multiple agents with similar efficacy, what is essentially the difference, especially since we have a lag time in their development, and we'll see how they catch on. But I think that Fred covered it, unless we see a magnitude of difference in efficacy, which is not expected. And given the fact that the devil is in the details, and each one of these trials have some difficult differences in their design or their selection or their assay usage, I think the bottom line is going to be towards the, kind of the part of safety. And for instance, niraparib that I've been involved in, at least claims from the ovarian experience that it may have a better safety profile. It remains to be determined within the cohort of these castrate patients. And again, back to Andy for his comment on it.
Yeah, I would say molecularly and preclinically, there are some differences in PARP trapping and some of the PARP isoforms that these drugs target. Rucaparib, which we haven't talked too much about, has additional targets, and Nima Sharifi's published a nice paper on one of these non-PARP targets that can actually reverse ENZA resistance. So but the data has to be there clinically at the maximum tolerated dose with efficacy data. So without comparative data or without unique safety data, we're just going to be making choices based on what's available and the evidence before us. Largely, you want level 1 evidence to make your decisions, not lower than that.
Sure. Yeah. Excellent summaries. Thank you all for that. With the time remaining, let's talk a little bit about the abstract that focused on this very unusual strategy. It's somewhat counterintuitive. Bipolar androgen therapy. It's got a pretty cool acronym, BAT, and they combined with olaparib for MCRPC. Andy, you and I were talking earlier. You've had some experience with this. If you could, inform us, and certainly love to hear from both Fred and Eleni on it. I have not, but they've been, Sam Dunmead done some really wonderful work at Johns Hopkins. What do you think about this interesting strategy?
Yeah, so having trained at Johns Hopkins, I had heard about this rapid cycling of androgens since I was a fellow, and Mario Eisenberger and many of his colleagues did some of the rapid cycling of castrate to supraphysiologic testosterone as a sensitizer to docetaxel, and that was called the MENS cycle. And that actually did not, pass muster. But Sam Dunmead took this on more as a way to reverse ENZA resistance and published the Transformer trial in the Journal of Clinical Oncology, a randomized study of ENZA versus BAT followed by ENZA, and showed that about a 30% group of patients had a phenomenal response. But the overall progression-free survival was no different with just ENZA. There were some unique responders in those trials, particularly patients that had DNA repair deficiencies. And the mechanism of BAT, where you're rapidly cycling the androgen receptor on and off the DNA, is thought to induce DNA damage and an inflammatory microenvironment in the tumor. And so they've moved on at Hopkins to looking at new combinations of BAT with checkpoint inhibition, or BAT plus olaparib, or BAT plus platinum, to take advantage of that DNA damaging effect. It's really not a hormonal effect. even though you're using the androgen receptor. And so Mike Schweitzer in this ESMO abstract presented the first data of olaparib plus BAT. And actually, of all the abstracts, I was most excited about this because in the homologous repair proficient patients, they actually showed a 40% response and progression-free survival of nearly a year, which was in all comers. And the patients that had homologous repair deficiencies had a little bit of a better response there. But, BAT therapy is very well tolerated. There are some patients that can have pain flares. You do see the rapid surges in testosterone, which can result in some mood changes in our patients. And when I counsel men where I'm giving this off label, you do worry. Patients sometimes can't believe that you're going to give them testosterone for the first time in a decade. They worry that it's adding fuel to the fire. And, they were very careful at Hopkins about selecting patients who were eligible for this, who did not have pain or imminent spinal cord compression. So you have to be very careful about selecting patients. So with appropriately selected asymptomatic or minimally symptomatic patients where that risk of progressive disease is not major, I think, it's a reasonable research question right now to move on to phase 3.
Yeah, that's great. Great summary. Absolutely fascinating. And, so many counterintuitive aspects, exactly as you're saying, there's a crosstalk effect as opposed to actually amplifying AR susceptibility. So that's really remarkable. But yeah, we have to be very cautious because some patients might obviously be put in tremendous jeopardy if not using testosterone supplementation appropriately. So what a great conversation. Let me just give you all maybe just a short opportunity to, your take-home points or messages you want to leave with our colleagues before we close. Eleni, would love to start with you first.
Thank you. I think we're on the cusp of further changes in the treatment of prostate cancer. We see the waning of androgen signaling inhibition over and over and over again. We just saw it again, as was mentioned by the beautiful data presented by Andy, the closure on the Arches trial, the Stampede arms. We saw the Peace one, but it is time for the new targets, the new agents to be further developed. And we're starting to see a glimpse, you're seeing all this interest with the different abstracts presented. But I think in the coming 2 to 3 years, there will be major evolution in the prostate cancer therapeutics. And hopefully the discussion that we're having is going to be moved up front to the hormone naive setting, especially for those patients who really need it, given their poor prognosis.
Yeah, that's awesome. Fred?
So in a short nutshell, it's, I think testing needs to be more widespread. We heard this. It's still very, very underutilized. So patients are not identified. But when we do identify a patient, very much like we saw with the hormonally based therapies earlier, it looks like it's better. And so identify these patients and treat them early. The only treatment I discourage in terms of sequencing is going from one hormonally based therapy to another. That is a waste of time and a potential loss of life. And that's what we saw in Profound. So find these patients and treat them early until we have the data to support an all-comer population.
Yeah, super important message. Thank you for that. Andy?
Right. So I'd like to summarize ESMO as being the culmination in the moving of AR therapies earlier and earlier, where we finally saw in Stampede again more cures, I think, with abiraterone in localized but high-risk patients, better survival, where now you can actually stop the therapy and patients are not having relapse. And the ultimate goal of the medical oncologists are really to cure our patients and not have to subject them to lifelong systemic therapy. So the best way to treat MCRPC is to never get it in the first place. So I would like to see, some of these combinations moving into earlier and earlier settings. We do worry about PARP inhibitors because they're DNA damaging agents, creating more resistant tumors later or secondary malignancies. We actually haven't seen a lot of that data yet because the Profound study was much later. But as we see from Propel, the clinical benefits may be substantial in this castration-resistant setting, that might motivate us to move into earlier and earlier settings, like we're seeing with the AR inhibitors. But we'll see.
Yeah, great points. And as Eleni said, congratulations on presenting the OS data for ARCHES at ESMO. Great work on that. Great work by Fred and the numerous trials and abstracts and podium presentations. And Eleni, your work and your reviews at ESMO were absolutely astounding as always. Thank you so much for your time today. Great pearls for our colleagues on so many different levels. Thanks very much to eCancer for allowing us to get together and have a collegial conversation. I wish everyone great success. Amazing things that are happening in advanced prostate cancer. Thanks very much.
Thanks.
Thank you, Neal.